The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
And good afternoon to all of you. I'm your host, Joe Basha, perfusionist and host of PerfWeb and Perfusion Education. We're here today for Corona 30, Part 1, Day 4. So it's a 3-part series, 5 days a week, Monday through Friday, conveniently scheduled to work around your schedule. And look, I do want to say the whole reason I started this Corona 30 project was none of us really knew how long it was going to take before the country got opened back up again. And of course, I recognized that a lot of my colleagues need to have Category 1 CEU and for the ABCP in their filing. So when I did this, originally I was thinking we were going to be shut down a little bit longer. I'm really, really relieved to see that we are opening up. And I recognize that, you know, there's going to be opportunities to go to meetings, but we're going to keep on. We're going to still do the whole Corona 30, all 30 CEUs. And anybody that's been affected, of course, if they need financial assistance, don't hesitate to ask us. I'll talk a little bit more about that with our website. Just send us an email. But most importantly, I want to thank our sponsors, LivaNova and Siemens Diagnostics, both of them very generous, very helpful. Couldn't do this without them. We really need them. So please check out what they have, check out their resources, check out their tools that they have for us as perfusionists, and give them consideration. I think they deserve at least that, certainly. Social media, we're on every platform. Of course, we'd like you to like us on Facebook, follow us on the Twitter, share us on LinkedIn, and make sure you subscribe to our YouTube channel if you have not already done so. Even if you have, make another email address and subscribe again. Give us a thumbs up. And also, don't forget to click that notifications bell. But most important, subscribe. By the end of this program, I'd like to get 10,000 more subscribers. Very important to us, please. Check out our websites and resources if you'd like to join our faculty, which continues to grow. And we have some great people that come on to faculty. I'm so impressed with all of them and so appreciative of their willingness to essentially take time out of their very busy schedules to talk to us and give us some really good information. It's appreciated tremendously. But if you'd like to be part of our faculty, or you have a topic you'd like to discuss, or you have a case report that you'd like to give, just email me at that address, contact@perfusioneducation.com, and you can be part of our faculty or do a case report or be part of the discussion or whatever the case may be. When you see this symbol, of course, you know the phone lines are open, and so please feel free to call in. We're going to open them earlier today than usual and leave them open throughout really a lot of the program. Maybe not the very beginning. We're going to let our esteemed faculty, John Ingram, have the floor uninterrupted for his presentation, because I think it's a very interesting presentation, very useful for a lot of people. Now, on May 6th, I believe it is, Patrick O'Toole is going to be giving a talk on scavenging of your volatile anesthetic from your oxygenator while you're on bypass. If you would please, for him, go to this, use this QR code, or go to that website, sli.do or slido.com, either one works, and type in where the hashtag symbol is, perfwebc30-8. Then, of course, you can probably figure out that's the 8th program in the PerfWeb series. But with that said, if you go there and vote, you can vote on, are you scavenging anesthesia gases from the outlet of your oxygenator while on bypass? So you could use your QR code, do it on your phone, or you can just type it in your URL on your computer and type in for the hashtag perfwebc30-8. Okay, I think that's it on that. Let's introduce, if we can, John Ingram. John's coming to us today from Orlando, Florida. John is a graduate of UT, University of Texas, and the Texas Heart Institute. John he graduated with honors. He graduated magna cum laude. Of course, I graduated magna cum nada, but that's okay. We can forgive you for that job. You know, hey, you're smart. You know, it's all I could say. You're very smart. You're board certified by the American Board of Cardiovascular Perfusion. You specialize in adult perfusion. You also do pediatric perfusion and adult ECMO. And where you are, you do a lot of adult ECMO. I know that. You've patented many things. You've published. You've presented nationally, internationally. You have, at 15 years, as a chief perfusionist or a department head director, if you will, so that management level experience. And currently you're working, from what I understand, doing long-term or I guess you could also say mid-term locums work, but you've been in Florida or in Orlando for so long, it's really a long-term, it's almost like a full-time job, really, it sounds like to me. But hopefully I did your introduction justice. And I will turn the floor over to you, John, for your presentation on ECMO Cannulation Basics. It's a very important topic right now, given the current climate that we're in. So welcome, John.
Hey, Joe, nice to see you again. Hope you're doing well. And things are nice. The weather's nice here in Florida, so hope you're doing well there in Houston.
Thank you. We are. We're doing really good. Actually, they're opening the city up, and things are looking a lot better.
Yeah, here too, a little bit, slowly but surely. Starting this week, open the beaches. That's about it for now. I guess more to come next week.
Yes, absolutely, absolutely. I think we're doing really well. All right, so you ready? I've got the clicker, John. So I know we're going to do this kind of a free-form style. You may stop and ask me a question, or I may be interrupting you as you go through your slides. But let's just go for it and see how it works out, and we'll just, as necessary, interrupt each other.
Yeah, so, Joe, when we talked a month or so ago about this COVID-30 idea that you had, thought it was a great idea. And this particular lecture really is a platform for my lecture tomorrow, which is going to be more than just basic ECMO. It's going to be some pretty serious problem solving, some hybrid cannulations, and why do we do these different cannulations. So anybody who is very experienced in ECMO could get a nice review today. Anybody who's sort of new, or you feel like maybe you could use a review, or you not do very many ECMO, this lecture today is really going to catch all with a giant net, no matter how basic your information might be about ECMO. We're going to kind of rope it in and then go up from there. And so I call it basic strategies. I'm going to start off with sort of what ECMO is and just build up from there, because you can't really appreciate why we're cannulating the way we're cannulating if you don't understand what it is we're trying to do. So that was sort of the premise of today's lecture. So this is the title, and as you know, I don't have anything to disclose on this topic.
Mm-hmm.
So we can go on from there. And so basically what we're going to be covering today, the name of the lecture is ECMO Cannulation-Basic Strategies, but we're going to ask, what is ECMO? We're going to say to look at all the indications and contraindications, or at least a good number of the major ones. Then we're going to talk about how cannulas are inserted, go over that briefly. Then we're going to focus on VV ECMO and the indications and the contraindications, but we're going to look at the role and strategies of why we cannulate the way we do. And then we're going to look at the advantages and the disadvantages of each one of those. And then we're going to do the same thing for VA ECMO. We're going to look at the role and strategies for veno-arterial cannulation, the advantages and pitfalls there. And what's after that, Joe?
Oh, sorry.
And so
just yell at me. Next slide, Joe. Next slide. Mm-hmm.
That's fine. Yeah, you're doing great. So today's lecture is, and I put the date there so that you would realize if you watch this in the future and you're playing it back, that today's lecture is really a nice platform for going into a lot more detail tomorrow. But tomorrow's lecture is going to be, how do we optimize what we're doing? It's not simply problem solving and the same thing that you've seen, but what we're going to talk about tomorrow is making changes and adjustments to the basic ECMO strategies we're going to talk about today, and how do we optimize our care. And I think that's going to really touch a lot of nice points with people. So like I said, let's start a little bit from the beginning. And what is ECMO? Well, ECMO is extracorporeal membrane oxygenation, as you know, also known as extracorporeal life support. It's an extracorporeal technique whereby providing prolonged cardiac and or respiratory support to, go ahead, Joe, to patients whose heart or lungs are unable to provide an adequate amount of gas exchange or perfusion in order to sustain life. So that's what we're doing with ECMO. So basically, there are two general types of ECMO that you hear about, VV ECMO or VA ECMO. And there's a lot of hybrid variations and even combinations of those two, but it starts off with these two. And before I go too much further, I underlined VV and VA for a reason. First of all, nomenclature in ECMO can be confusing to people who aren't around it a lot. When you look at VV ECMO there, what I've written, you see where there's a dash in between the letters? Wherever you see a dash, no matter what the letters are, there could be VV-VA. There could be a lot of different combinations. The dash tells you where the oxygenator is, where the ECMO pump oxygenator is located in that nomenclature. And the first letters of it before the oxygenator are always going to be withdrawing or draining blood from the patient. Then it comes through the oxygenator, i.e. the dash, and then it returns back to whatever letters are after the dash. Okay, so that's something, if you've never been explained that, will be helpful to you.
So John, can I interrupt you?
Yeah.
John, can I interrupt you? So technically what you're saying is that even though, keeping it simple, we're talking V-V, V-A, like you just described. But if you were coming from the left atrium, it would be LA-A. So if you're going into the femoral arterial system, so it would be AA, but it would be from the left atrium versus from the venous system. So if you were doing a left heart bypass,
it doesn't have to be venous. That's
correct.
Exactly why you need to know where the dash is. It doesn't have to be venous. You can drain the left atrium. You can drain the left ventricle, so it doesn't necessarily have to be a venous drain, but at least the dash tells you where you're withdrawing from, whether it's venous or arterial. Now you need more details than that. When you start draining the left ventricle or the left atrium and things like that, usually you're going to need to explore the circuit a little more as to those hybrid type things we're going to talk about tomorrow. And the nomenclature is still sometimes under development of what ELSO recommends and what some people use out there. In fact, where I work, we don't actually subscribe to exactly the nomenclature that ELSO recommends. So sometimes you hear things different out there.
Everybody certainly has to be on the same page with whatever it is we're doing, right?
Yeah, and that's part of the reason why the nomenclature is trying to find a home base. And it's overall generally agreed upon, but I would say about 20% of the places still use kind of their own little twist on the nomenclature. Some people call access, other people call it drain. Some people call it return, some people call it reinfusion. And at our institution, we love the term drain, but also actually likes the term access as meaning venous access, but it's not always venous. That's the problem. You could be draining a left ventricular apex. You could be draining a pulmonary vein from the left atrium. So whenever we talk about return, we know that we are pulling from the patient. And when we talk about drain, when we talk about return, we know we're giving that oxygenated blood back to those particular vessels. So we've decided we like our nomenclature better at our institution. So in establishing VV or VA ECMO, though, it does depend on what the underlying disease of the patient is. However, sometimes, more than sometimes, the severity and the rapidness of which the patient is declining may not allow us fully enough time to diagnose exactly which is the problem. And in those cases, VA ECMO is a giant net and catches those things, and later we can modify it differently. So let's look at what is VV ECMO. So VV ECMO is for patients who are experiencing respiratory failure. VV ECMO is not for patients that have experienced any type of cardiac failure. And so principally, the VV ECMO device, the circuit itself, functions as an artificial lung with no direct circulatory support. And I will say the reason I underline that, no direct circulatory support, it's not helping the cardiac ejection or function at all. The only support that some people will claim from a VV ECMO is that the increased oxygenation that we're providing that then makes its way to the coronary arteries, which it wasn't doing before, that increased oxygenation coming down the coronary arteries sometimes improves and acts as an indirect positive contributor to circulatory function. But it is actually not, as of a device itself, contributing anything to the circulatory support.
That is a great point. And actually, I threw some slides together for my talk, and I'm so glad you brought that up.
Yeah, some people don't think about that. So VV ECMO, again, is basically indicated in patients with severe respiratory failure that's refractory to optimal mechanical ventilation and medical therapy. That's the basic concept. When you've already exhausted your maximum ventilator support and maximal pharmacological support, and your patient is still failing pulmonary-wise, VV ECMO is the stop-stop measure there. For the goal of VV ECMO, now this is a take-home message for people who don't do ECMO terribly a lot. The goal of VV ECMO is to oxygenate at least 60% of the patient's cardiac output. And it quite possibly could be more than that. But the reason I point this out is that when you're selecting cannulas, and we're going to talk about cannulas here shortly, when you're selecting the size of the cannula, you should do a quick assessment of your patient's cardiac output and see if you're going to be able to flow and capture with the cannulas you're inserting 60% of the patient's cardiac output. See, 40% of it is going to get past the cannulas in this case, and you're not going to be oxygenating that 40%. And it's left to the lungs to contribute something, or maybe they don't contribute anything at all. So what are the indications for VV ECMO? Well, hopefully it's reversible respiratory failure, which could include ARDS is the famous one, acute respiratory distress syndrome, but that can be due to a number of things. These are some of the more common ones. Bronchopulmonary aspiration of some sort of fluid or food particle. You can have a noxious inhalation of a toxic chemical or smoke inhalation. You can have any variety of pneumonia, a bacterial, viral, even atypical pneumonia we do see. You can have chronic interstitial pneumonitis, acute or chronic. You can have some form of barotrauma that's occurred to the lungs. You can have a pulmonary contusion in which bleeding occurs inside the lungs and is plugging up vast amounts of the alveoli. You can have something called alveolar proteinosis. This is a syndrome that you don't see too often, but it's a syndrome of a buildup of the surfactant in the alveoli. The patients have a syndrome whereby they don't remove the excess surfactant rapidly enough, and it actually builds up so much that it actually blocks the alveoli. So severe asthmatic attacks, severe asthmaticus, status asthmaticus with severe bronchospasms that don't relieve very well might have to be put on ECMO. We always see several asthma patients per year in our center that do end up on ECMO. Usually it's a short run, 2 to 3 days, but we do see that. Any form of airway obstruction, really, could be a foreign body, could be a growth, could be something that's restricting airway, anything that's obstructing the lungs function, we can take over with VV ECMO. And I think there's one more there, Joe. Nope, okay. So what are the contraindications for VV ECMO? So, you know, with ECMO in general, if you have a patient with a highly advanced terminal or in particular irreversible disease, is really no point on putting the patient through an ECMO run. Go ahead, Joe. So uncontrolled sepsis is one that sometimes we wouldn't put patient on ECMO for. Go ahead, Joe. There's a little bit. Non-pulmonary multi-organ failure, irreversible brain damage, irreversible neurological injury, any type of terminal illness, metastatic cancer. So chronic respiratory failure or a ventilator-dependent patient in respiratory failure are not going to be eligible, if they're not eligible for a lung transplantation, are not going to be put on VV ECMO. So let's ask the question, what is VA ECMO? So VA ECMO is for patients who are experiencing acute, severe cardiac failure. And it provides direct circulatory and respiratory support. So that's the key thing about VA ECMO, is that it is going to take over for your heart and your lungs. So if you're not sure in an emergency situation why the patient has gone into shock, cardiogenic shock, respiratory shock, if you're not sure, you don't have time to diagnose, VA ECMO is usually the first thing that's going to be tried. Then we'll sort it out later. So VA ECMO is indicated in patients with primary cardiac failure resulting in cardiogenic shock or cardiac arrest that's refractory to conventional medical therapy. And here, you talked about the goal of VV ECMO being a 60% of the cardiac output. The goal of VA ECMO is a little bit more elaborate because, again, we're taking over for the heart and the lungs. We should be able to, on VA ECMO, maintain a reasonable mean arterial pressure of 60 or greater. We ideally would maintain an arterial saturation of greater than 85%, and we should be able to maintain normal carbon dioxide, normal lactate levels, and normal pH levels. And a little bit of a take-home message here for people who are not very well adept at ECMO is your lactate levels on ECMO will always tell you a lot. If you have started off with a high lactate because the patient's in failure and you put them on ECMO and your lactates are coming down to normal, generally is a very good sign you're doing something right. The reverse is also true. If you're on ECMO and your lactates are continuing to rise or stay elevated, you need to look into improving what you're doing.
Well, that could just be dead gut.
Yeah.
Yeah, because that's
if
you've
got
had
problems if your lactates aren't coming down.
Yeah, if you've had Levofed on, for a couple of days at 28 mics or higher, good chance you're going to have a big old bowel infarct.
Yeah, we see that, unfortunately.
Mm-hmm.
And so what are the general indications for VA ECMO? Cardiogenic shock or heart failure, and it can be as a result of an MI. We see this on severe myocardial infarction patients, different forms of myocarditis.
Now that myocarditis, they were thinking that there was going to be, or that they were saying in the beginning with this COVID issue, that it was associated with myocarditis with a lot of patients. I never saw it. We had one patient, we suspected that was the problem, but it wasn't. It was an MI from coronary artery disease, and he ruptured his RV from the big MI. So, but he didn't have myocarditis. And he ended up COVID negative on top of it. So, but I haven't seen the myocarditis in COVID patients. I don't know if you have.
No, there was an article that came out about 2 weeks ago. In fact, I forwarded it to our surgeon, our ECMO surgeon, and claiming that there was a higher than normal incidence compared to even patients that get septic or with the flu. Regular flu will have some occurrences of myocarditis. So there was someone who published a paper, I didn't read it in detail, but basically you're right, claiming that there was a fairly high, much higher incidence of myocarditis with COVID, and I'm not sure if that's going to bear out in the end of the day or not.
Mm-hmm.
You can have patients on VA ECMO because of the sepsis and the cardiomyopathy that can be associated with that. You can have patients that are in chronic cardiomyopathy, but with that, you're going to have a game plan as to what you're going to do with the VA ECMO. Now we see this, at a heavy cardiac transplant center. Sometimes the transplanted organ has suffered a long ischemic event or other setback, and will have to come out of the OR on ECMO. And generally, after a period of time of the heart recovering, those patients generally will come off ECMO, and the heart can recover. We have this is one thing that happens a lot, and it's been around for many years, is unrecognized isolated right ventricular failure. That goes undiagnosed probably as commonly as anything. We've gotten better at it, but there are still a lot of places that don't put in a Swan-Ganz catheter, or the patient has crashed due to right ventricular failure, and we can't figure that out until after the fact. Pulmonary embolism, certainly you need immediate VA ECMO to take over for the cardiac failure that goes along with it, and the pulmonary failure that goes along with that.
This is a big deal too. I've had several people several of the physicians that I work with in various locations try to establish a true PE response team, which includes putting the patient on ECMO as a primary means of support before decisions get made about what are we going to do with this patient. Do you guys have that in your location, in your hospital? We don't really have that as an established response team in any of ours. We've talked about it, but never really have done it.
Not that I know of, and it's a hard diagnosis if you have to do it quickly. If the patient is suddenly experiencing a massive PE, most of the time you're not real sure that's what happened until later.
That's right.
I mean, it's just so hard to know that's what's going on. You can look at some things, but usually you don't have the time to sit there and peel through the layers to figure out that that's what's going on. But you have a severe respiratory collapse, probably followed by an immediate right ventricular cardiac collapse, and it's all hands on deck to go on VA ECMO. Usually then you get chest x-rays and things, and you find out the patient had a PE. Hopefully you responded quickly enough.
Well, if it's a saddle block, I mean, all the CPR in the world isn't going to help.
Right. So post-cardiotomy syndrome, that's basically post-open heart surgery. Patients that, had a very long or difficult procedure, or just had untoward ischemic time that wasn't overly well protected, might have to come out still on ECMO. We see this with some frequency. Patients that have just an absolute refractory ventricular VTAC or VFib that we keep shocking them out of, but they go back into it, and we can't seem to resolve it with maximum pharmaceuticals, and they have to be on ECMO at times. Patients with sudden cardiac arrest, pretty much what we were just saying. Now, inside the hospital is one thing. Outside the hospital, they're really starting to put confines on the cardiac arrest having to be a witnessed arrest. It would have to be CPR was done in a short period of time after the arrest. I think it's a 38-minute to 1 hour arrival in the ER from the paramedic team, and there's the unwitnessed cardiac arrest. For the most part, people are reluctant to put them on VA ECMO because you end up with a corpse on ECMO, unfortunately, in a lot of cases.
Brain dead, But and the other thing too, witnessed arrest CPR, but it's very important it's effective CPR.
Yeah.
So people really do need, if they're going to jump in there and start providing CPR to people, that they really do know what the guidelines are and do it effectively.
Yeah, the arrest out in the field in the public is always a dicey one. So, people go on VA ECMO if they're on a bridge to transplantation, they're decompensating, their heart isn't, they haven't received a donor heart yet, and they need more time. They can also be a bridge to obtaining a durable VAD. And I think the last one there, Joe, is a bridge to recovery and also a bridge to decision. And, the bridge to recovery is basically what ECMO really does. If nothing else, it gives your organs, whether it's the lungs or the heart or both, opportunity to rest and recover from an acute insult. So sometimes it's just time that patients need, and hopefully that's where it ends up with most of our patients. But some of them, we put patients on ECMO and we have to put them on for a while and then decide if they're going to be able to go anywhere from there. Sometimes they do, sometimes they don't. So the contraindications in general for VA ECMO, similar to VV ECMO, you wouldn't put anybody on with a terminal or irreversible disease. Uncontrolled sepsis, similar to VV ECMO. Multi-organ failure patients, irreversible brain injury, these are all similar. Metastatic cancer or terminal illness, they won't be able to recover from. So a patient who has irreversible cardiac failure and they're not eligible for a durable VAD or cardiac transplant is basically a bridge to nowhere if you put a patient on VA ECMO and they have no qualifications for any exit strategy. So, and also if a patient has severe coagulopathy, contraindication to anticoagulation, and sometimes this even includes advanced liver disease. Aortic dissection, obviously, you're going to have to cannulate the aorta in some fashion. So if you have a dissected aorta, you're not going on VA ECMO very well. And then sometimes we run into this, you have patients that just have severe peripheral artery disease, extreme obesity. I see that one in all the journals and the books, but I tell you what, we've put some extreme obese people on ECMO and figured out a way to do it. And then, of course, if you just don't have access due to amputations and so on, could all be limiting factors on VA ECMO. So let's talk about the basic insertion techniques, and there's basically two everybody's probably aware of. You have the Sellinger technique or the Percutaneous technique or the surgical cut-down technique. So let's take a look first at the Percutaneous. It's really the most commonly used approach, and nowadays we have the advantage of using ultrasound visualization of the vessel. That's pretty much a standard of care most places, to use the ultrasound. As you can see in the bottom there, you can really visualize the vessel very well, and then you would go ahead and insert.
Do you want me to show that, John? Right here. Let's see. I'm looking for my mouse. There it is. So here's the vessel right here.
Yeah, exactly. And
so you can
actually
see it very nicely.
I believe that's a bifurcation of it above there, if I'm not mistaken. I'm not sure. But we, at our institution, the PAs and the surgeons and the physicians can cannulate people even in the most difficult situations due to that ultrasound. And once you locate the vessel in ultrasound, you can really do a needle puncture, find the vessel, and then you're going to go ahead and introduce guide wire. Usually a J-tip wire is what most people would use for most things. That's safer. And then once you get the guide wire in, you're going to go over that with graduating increased sizes of introducers. Of course, that's stretching and distending the surrounding tissues to prepare it for the large cannula that you're about to insert. And then finally, when you do that, you take the cannula over the guide wire. You're going to withdraw the guide wire, and then you're going to be left with a cannula inside the patient. Go ahead, Joe. And here you basically need to prime the cannula, de-air it with the patient's blood most of the time, and then make an air-free connection to the circuit, usually similar to what you do in the operating room. So in the surgical cut-down technique, usually it's reserved for hard to get vascular access in patients, whether it's because they're in hypovolemic shock or just for whatever reason peripheral cannulation is too difficult or impossible. And what you would have there is a simple exposure of the vessels, and you see the tie downs there and isolating the vessel, and then you would basically just go ahead. You would basically insert the cannula under direct vision, and then you'd have the tie downs there for security. Basically the same that you've seen in any type of vascular surgery or open heart surgery. So now let's look at VV ECMO and the role and strategies of these. We're going to go through, the cannula strategies of a few different types of VV ECMO, and the same thing for VA ECMO. And again, keeping in mind that today's lecture is really a platform for tomorrow's, when we really get into hybrid variations of all these. So you really have two classic venous cannulations that's been around really since the beginning. And the first one is the old standby femoral vein and jugular right. Usually it's the right side. Usually it's the right femoral vein and the right IJ. And you would stick a pretty long cannula into the femoral vein up until about the level of the right atrium or just below it. And then you would withdraw the blood there, and you'd return oxygenated blood back up to the right IJ, and hopefully aiming that back into the right atrium. And then the second is, if you can't, for whatever reason, do that, the next best thing has history, in the classic days have been a double venous femoral VV ECMO, where you use both femoral veins, and one cannula similar to the one I just mentioned would go all the way up into the right atrium. That would deliver your oxygenated blood, and then a shorter one in the other vein would go up, and we're going to look at this in a minute, about to the level of the hepatic vein, withdraw deoxygenated blood, returning oxygenated blood, hopefully back into the right atrium. So we're going to look at a little bit of both of these here closer. So looking at number one, go back for 1 second there, Joe. Yeah, that's okay. Looking at number one, it's a classic, as I said, a classic VV ECMO, and it is achieved with two separate cannula, as I said. And then, go ahead, Joe. Then looking at the interior of what's really happening inside the atrium and in the IVC, SVC. So one cannula is usually inserted into the right femoral vein. It can be the left, and it's advanced basically to the level of the IVC right atrium junction, but it's really about the level of the hepatic vein. And then, go ahead, Joe. Then the other one is inserted into the right IJ, and it's advanced down through the superior vena cava into the right atrium. And it's very important in this cannulation technique that this cannula is aimed towards the tricuspid valve. We're going to talk about why that is. So, as with most ECMO, the size of the cannulas directly affects the amount of drainage, and therefore is going to be your determinant of your blood flow. So, of course, you want the largest possible venous cannula that will maximize your flow, and it will achieve your 60% or greater target output of of venous VV ECMO flow. So on number 2, this is a FEM-FEM VV ECMO. Again, you're going to use 2 cannulas. This is usually done if the IJ cannula is not possible, and it's an alternative to that technique. And this involves bilateral femoral cannulation of the venous, both venous. So the tip, again, of the drainage cannula is going to be advanced pretty much the same as the other one, about to the level of the hepatic vein. And then the second one, and the return cannula is going to be positioned right into the right atrium. And as you can see, unfortunately, why this technique is not as preferred as the previous is that there's no way to aim that cannula towards that tricuspid valve. And so you're delivering oxygenated blood through the side holes and through the end hole, and you're really hoping that the oxygenated blood makes its way over to that tricuspid valve. And so again here, the largest possible cannulas are going to get you in the best flow and hopefully achieve your target flow. So basically summarizing, these are the 2 classic configurations. Again, as I said earlier, if you're new to ECMO and you want to start from the basis and build up, this is your 2 classic. And by the way, Joe, our surgeon decided with our COVID ECMO patients that all patients would come in and immediately get number 1 there. Right femoral, right IJ. No questions asked. Every patient came in with COVID. We had an OR set up with everything just to do just that, so there would be no muss, no fuss, no spending of time. And this is how we've done all of our COVID patients. Have you seen that?
No. The 3 we've ended up with 3 total. All of them were 2 of them were with a single double lumen catheter technique, the Avalon, and only 1 was double cannulation, and that was because of some other challenges involved. I think it would have been preferred to still do the single cannula.
Well, the funny thing is that was our go-to method. We did, the Avalon or Crescent cannulas almost entirely.
Can you tell me?
It was really unusual to do the other.
Can you tell me the reason for it?
And all of a sudden with this, we can you hear me?
Yes.
We went straight to this technique. And,
can you tell me why though? What was the reason?
Well, I actually tried to talk him out of it, but I don't know. I just think he wanted to standardize it. I think it was less, need for. Well, one reason was it was less need for Cine to come into the room.
Yeah, fluoro, no fluoro.
And there was less people to come into the room. And also the other reason too is we have a very large hospital, as you know, and so transporting these COVID patients from the OR all the way to the unit down the hall, we actually converted one of our ICU, in our COVID ICU, one of the rooms was converted to an insertion room. Mm-hmm. Mm-hmm. So the patient could come there, get inserted, and the only movement they had to do was right next door to the room that they were going to stay in. And so that room didn't permit all this excess equipment either. So I think it was just the safest, simplest way to get people with VV support.
I think that makes sense.
Yeah. Because I don't know about in your hospital, but when we transport these COVID patients, it's a major production. Everything has to be shut down. All the doors have to be closed. Everybody has to be locked away. Yeah. Security has to clear the halls.
Yeah, I have to say, I'm not sure I understand that. Once the patient is intubated and, essentially anesthetized, probably paralyzed as well at that point in time, and on ECMO, I'm not exactly sure I understand the basis for that. It doesn't really make sense to me. We have been transporting and still do infectious patients all over the hospital, but for some reason this one was treated in some special, unique way. Now, in the beginning, when I think there was a level of uncertainty with the disease, I think we know a lot more than we did then. I could understand that. but at this point, that for me doesn't really make a lot of sense.
Yeah, the interesting thing was when all this happened, we were all asking questions about, the exhalation gas on the ventilator in the OR, was that scavenged? Mm-hmm. And apparently it is scavenged. And then when you get into the ICU, when you have intubated patients, is that exhalation gas scavenged?
Mm-hmm. It's filtered.
And I think the answer, and I don't know that it is hooked up to the wall suction.
Well, I don't think it's hooked up to the wall suction, but I think it has one of those filters on it. But whether or not that traps this or not, I don't really know. It's a very good question, but I imagine that the way ventilators are made, it has to be a closed circuit in some way. There has to be something that protects that.
Yeah, all of a sudden, all these concerns about the exhalation gas that I would have thought have been long since thought of were brought up and discussed by pretty high-level people.
how many people are on ventilator that have TB? Everything. Everything else you can think of. Influenza. Influenza's it's an airborne ventilator. It's transmitted in the same exact way with respiratory droplets. It's the exact same. It's the exact same method of transmission. Mm-hmm. However, and with that said, in the beginning, again, I understand people's angst when we didn't know how fatal this really was or wasn't. I think now that we have a better handle on it, I think we've had a handle on it for a while now. I think that whole episode of shutting the entire hospital down to move the patient that's intubated from point A to point B, in my view, really doesn't make any sense. But I don't want to debate the issue. I'm not arguing with you. I'm just telling you my opinion. It's an opinion, right?
Yeah, well, that was based on why we were doing that cannulation and trying to minimize transport. And yeah, we've seen some interesting extremes that have arisen. Mm-hmm. And so, those were the two old school classic ways that are still around and heavily used. And then, of course, in not so many years ago, the Avalon cannula and the Crescent cannula came out, and they're very, very similar, almost identical in some ways. But this offers a single cannula insertion into the right IJ, and it goes down through the right atrium and into the IVC, and it does that because it has 3 ports, and it has a proximal and a distal port, which are going to retrieve or evacuate unoxygenated blood from the IVC and the SVC, and then the middle port. Go ahead, Joe. The middle port is going to return the blood to the oxygenated blood, and hopefully is aimed directly towards the tricuspid valve. That's very, very important with this particular cannula, that you have to have this cannula positioned correctly, and it needs to stay positioned correctly, and it needs to be secured down well. And so if you do, and you aim this, and you can verify this on TEE in the OR when you're doing this, that it's directed right towards the tricuspid valve, you'll get a minimal amount of mixing with this. But if you do not do that, you can get a significant amount of mixing with this.
Mm-hmm. Yeah, in fact, we had a very good talk Dr. Duvall did for us on this, and it had to do with sort of reading X-rays, MRIs, CTs, and TEEs. And so when you put this in, you want to get that bicaval view with the TEE, and that way you can see both cava, and you are actually able to look right at the tricuspid valve in the middle of the view and see the color jet aiming towards it, and you can actually see it if you have the right view.
That's all part of the proper insertion technique for this. And here it's interesting. We always talk about larger cannulas, we can flow more, but here it becomes more pronounced, because even though it sounds like you're putting in a large cannula, it's two smaller cannulas inside a larger casing, so to speak. So I know you can only fit such a size into such a vessel and everything, but this one here, you do tend to see, and we're going to talk about and when we get later here on the drawbacks and advantages of these, higher pressures generally because of that.
Mm-hmm.
So this is where we're going to start talking about the advantages and pitfalls of these three different types of cannula. So those are the three we talked about, and we talked about what they look like and what the flow characteristics are. So now let's look at, advantages and pitfalls and why you might do one over the other. So here's the first one we talked about, the femoral and jugular right IJ. And so because you have two cannulas, you're going to be usually able to have good flows, high flows, because you're working with two separate cannulas as opposed to one. And you can minimize the recirculation if the superior vena cava is aimed at the tricuspid valve, as I mentioned earlier. And so I stress this again because you can imagine that if that cannula is facing directly down, that one is, shooting blood out of it at, let's say, 4 liters a minute. The one just below it is the drain cannula is suctioning 4 liters a minute. And if they're facing towards each other, you're going to have a lot of recirculation. Surprisingly to me, this technique actually works quite well. So it does require two cannula insertions. This is some of the drawbacks. And here's a real interesting one that goes on with this. Any IJ insertion, the right IJ, when you feed a guide wire down the right internal jugular vein, it is very easy, and we're finding out that this even happens sometimes, and we haven't even realized it's happened, and it's being explored more and more. It's actually very easy to perforate the coronary sinus or even the right atrium or right ventricle, because if that wire, as I first showed you, you have to feed a wire down a vessel, then follow with the dilators and the cannula. That wire, you better feed it way down into the inferior vena cava, into the IVC, and make sure that you have passed the eustachian tube there at the IVC in the right atrium. A lot of times it gets caught up in that and makes its way into the right atrium, over to the coronary sinus, sometimes even causing a PFO or ASD. And we actually saw this one day. We were doing one. I don't even think we realized that we had perforated something, but we started seeing right before our eyes on the TEE a tamponade occurring. And we were able to diagnose it as that the wire had actually perforated the right ventricle. Well, the right ventricle being a thick muscle closes that hole up actually rather quickly. And that's pretty much what's happened. And I think that's why people have gotten away with this and not even realized that they've done it. However, if you do that in the coronary sinus, you're going to have a lot bigger problems, perhaps, than if it's just the right ventricle. So, as I said, if the cannulas end up aiming directly towards each other, you can have vast recirculation going on there. So, one rule of thumb, and this is a take-home message for people who are not so adept at ECMO, you need to try to have a 15-centimeter distance between the tips of the two cannulas. That has been shown to minimize your recirculation between the two. So again, the largest possible cannula is going to maximize your flow, and it's going to reduce your negative pressures, which reduces circulation. What I mean by that is if you have a nice sized cannula in the superior vena cava to return the blood, if you happen to put in too small of a cannula in the IVC, the one that is withdrawing the blood, and you have to run high negative pressures just because of that, even though you have the cannula positioned correctly, aimed towards the tricuspid valve and 15 centimeters apart, that high negative pressure is going to aggravate and cause more recirculation. So again, a pitfall is you have a femoral cannula, and that's going to reduce the ability for the patient to be ambulated. So now we look at bilateral fem-fem VV ECMO, which is the second one we talked about earlier, and you saw the diagram, and you can see what it might look like on a patient there. So if we look at the advantages and pitfalls, so this is what it looks like internally. The advantages here are if you have two nice sized cannulas, you can achieve a nice flow with low pressures. Pitfalls is it does require two cannula insertions as opposed to the one. The return cannula, the one returning your oxygenated blood, cannot be aimed directly towards the right atrium. So most people see more recirculation with this technique. Even though the cannulas aren't facing each other, the disbursement of the arterialized blood in the atrium sideways and up and ends up coming back towards the drain cannula. Again, try to keep 15 centimeter distance between the two cannulas to minimize recirculation. And again, the largest cannulas are going to help maximize your flow and reduce that negative pressure that I was talking about for the drain cannula. And here you have two femoral cannulas, so most ECMO centers would not consider ambulating a patient with two femoral venous cannulas.
No, I wouldn't either.
I've seen it done, but it's not very likely.
Very bad
So
idea.
then the third one is a little bit more modern technique that's come along since, and that's the Avalon and the Crescent. And you can see there the diagram on the left and then what it might look like in a patient. And if you see the way that the arterialized blood is the curved one coming in there on the side of the longer cannula, that one has to be faced directly into the patient's side of his jaw or side of his neck. That's confirmation actually that the cannula is most likely positioned correctly. One thing that can happen is a patient will have his neck turned to the side when we insert it. Then when we go back and do this and position him comfortably, that has not been shown to turn this cannula from the preferred direction that we thought it was in. So this is what it looks like. We talked earlier. The advantages now, of course, it's a single cannula insertion, better than the double cannulations of the other two. And you will have minimized recirculation, provided that return port is aimed directly at the tricuspid valve. There's no femoral cannulation, which does allow for proning the patient. The patient can sit up and the patient can ambulate. And when you see a lot of videos and things on lectures and things where people are ambulating, most of the time they have this type of cannula in there. It also permits some form of physical therapy, and usually the patients can be awake with minimal sedation. So some of the pitfalls, though, are, again, back to what I said before, insertion of the right IJ guide wire, which can perforate the coronary sinus or right atrium or RV. You can, because it's one cannula, you're going to probably notice you're limited by your higher pressures, both on the negative draw side and on the positive return side. You're usually going to see higher pressures with this type of cannulas. Here's two big things I put in red. It must be positioned accurately and verified by TEE, transesophageal echo. And secondly, it must be secured in place, and the tubing must be secured so as not to kink. Now, in this picture, go back 1 second, Joe, you see where the U-turn is there. That is actually a specialized connector that a company makes just for this purpose. We don't have this at our institution. I have not seen this, but this is out there, and it's just for this purpose, because if you don't have some type of way to, well, the challenge is your cannula is going up out of the patient's neck, and the ECMO machine is generally over to the side or even at the foot of the patient. So you've got to figure out a loop or some way to not kink and get this tubing to come all the way back to your circuit. And with all the movement and sitting up and perhaps walking of the patient, sometimes these things are not secured enough and they can kink. So that's something you have to watch out for here. So now let's look at VA ECMO and some of the roles and strategies of VECMO. And we have two classic configurations here, and most people might be familiar with these. Number one, it's cannulating the right atrium, withdrawing blood, oxygenating, pumping it back into aorta, same as we do in routine open heart surgery. And then more commonly, though, for ECMO, it's a fem-fem VA ECMO where you have femoral vein and femoral artery cannulated. And go ahead and click the thing, Joe, one time. We're going to see really that number one is central cannulation, and number two is really referred to as peripheral cannulation. So let's look at the central cannulation. And of course, you have to have 2 cannula, one in the right atrium, one in the aortic root. And so you're going to have the one in the right atrium. Of course, the purpose is to drain the venous blood. And you're going to have the other one in the aortic root, which is going to return, to be the arterial return. And this is the same as bypass. And most of the time, the patients that end up in ECMO are actually going to have the same cannula in that you had on bypass, because that is one of the main reasons that this technique was employed, is for patients in cardiac surgery who could not come off our lung machine. And basically, we just learned many, many years ago, we could just connect the same cannulas up and go off and running on ECMO. And so with this, though, one good thing is you can have full cardiopulmonary support, and you're really only limited by your cannula and tubing sizes and the corresponding limitations that those bring, which generally are not very much with this large of a cannula that you're probably going to have. So on the peripheral side, this is going to involve either bilateral or ipsilateral femoral cannulation. You can have them on bilaterally, or you can have them on the same side. And the tip of the drainage venous cannula is going to be placed at the SVC level, just below the atrium, just past the hepatic vein. The return cannula is just going to be basically inserted into the femoral artery, and usually it's inserted a fair distance to just past the bifurcation most of the time. The largest possible cannulas, again, are going to help you for maximum flow and support. And with this, a distal limb perfusion cannula is almost always required, and that is a separate small cannula that needs to perfuse the distal limb of the leg that has the femoral artery cannula in it. We're going to talk a little bit more about this. So what are the advantages and pitfalls of both of these? So the central cannulation, the right atrial to aorta via ECMO. Here you have, it's easily converted from cardiopulmonary bypass. You're capable of providing full support. Pitfalls are the chest remains open. The chest is generally not closed when this happens. If that's the case, patients are heavily sedated, paralyzed. You can't, go ahead, Joe.
Hey, John, I didn't switch it because I wanted to talk about that.
Oh,
so
okay, good.
What we do, you know, and we have had to do patients where we've centrally cannulated and left the cannulas in, but we will tunnel. We'll either use one of those Viadrape wound vac type things on the chest and leave it open sometimes. But if they're dry enough, then what we'll do is we'll tunnel the ECMO tubing through the skin, just like you see there with the chest tube. And if the heart is small enough and can tolerate it, we'll either go ahead and approximate the sternum, but most of the time we'll just approximate the skin, leave the sternum open, but have the skin closed, and certainly going to reduce infection tremendously.
And that's exactly why I showed this slide, because anybody who may not do ECMO at their center may not realize that ideally, and most of the time, that whenever we can, we would try to tunnel the catheter and the tubing through the chest there, through the below the chest, and at least give you a way to close the chest as much as possible. Usually, it's like you said. In most cases that I've ever seen, the cardio edema, the myocardial edema, and the swelling and the size of the heart, and then with the cannulas in addition to it in there, rarely allow complete closure of the chest. Mm-hmm. And you know, at least that's been my experience. And I've seen days later when that myocardial edema went down that we were able to actually close the chest. Mm-hmm. I've seen that, but or never quite in the OR.
Or the heart's just stuffed, dilated, and you can't empty it.
Yeah, and it's, you know, exactly. And so because the patient's chest is open, they're going to be heavily sedated, paralyzed. You're not going to be able to interact with the patient. And you know that they're going to have to return to the OR if not once, more than once. For one thing, these cannulas are going to have to be either removed or reconfigured to some type of peripheral configuration, eventually, if they end up weaning this way, which is probably unlikely. Of course, you most likely have a lot higher risk of infection. You've got a wide open wound. We do protect it pretty well, like you said, though, Joe. I've seen a lot of care taken into, protecting against that. Mm-hmm. But the higher risk I'm talking about, too, of infection is the repeated procedure 2-3 days after the next, a lot of times going back. And because with these patients, they usually have been on bypass, regular cardiopulmonary bypass, an extended period of time. In order to end up on ECMO, they were probably on bypass a long time. Most of these times, you have a lot of bleeding and coagulopathies that go along with these open chest VA ECMOs. Mm-hmm. So the second one then that we see, if we can do VA ECMO on a patient in a more controlled setting, we would always try not to open the chest. So we would end up doing peripheral cannulation, which is femoral VA ECMO. And the advantage there is generally it's a pretty quick vessel access. You don't need to open the chest. You're capable of providing near or full support. Well, we can talk about that a little bit later. The pitfalls is you're back to 2 cannula insertions. You need to have the largest possible drainage cannula, again, to reduce negative pressure and maximize your flows. And that can be challenging in a vein sometimes. Mm-hmm. The patient's not going to be ambulated with fem-fem cannulation. And the big one here, and we're going to talk about this a little bit today and a lot more tomorrow, is that whenever you have a femoral artery cannula, you're giving arterialized blood retrograde up the aorta, and there's 2 big problems. One, you're flowing into and at the aortic valve, which may create left ventricular distension. I think you went the wrong way, Joe. Go the other way.
Oh, I'm sorry.
I think you're yeah, and then you also have this something called differential hypoxia. It goes by several different names, but as you can see, if you have highly oxygenated blood coming up the aorta, meeting with not so oxygenated blood coming out of the left ventricle, you can end up with deoxygenated blood going to the upper body and upper limbs, and most importantly, to the brain. So we're going to expand upon that a little today and more tomorrow. And again, here requires distal limb perfusion cannula to perfuse the distal limb. Now, many years ago, Joe, you may remember, we never did this. I remember back, 20, 30 years ago, there was no distal limb perfusion. And we had an awful lot of, even with balloon pumps, we had an awful lot of purple toes and purple mm-hmm. feet. Mm-hmm. And unfortunate.
I've got a couple of good pictures in my slide deck I'm going to show.
Okay, good.
I think you'll like
a distal limb perfusion cannula, for anybody who doesn't know, is a small catheter, really 5, 6, 7 French, put into the femoral artery, and it's aimed down distally towards the foot, and it's wide off, usually with just a lure port and a small pressure line with a stopcock usually, so you can manage it for things, and it's going to purposely perfuse that limb, and that's been a real big improvement over the years in ECMO, femoral ECMO, because we were losing a lot of limbs before this came along. Okay, so thank you guys so much,
good.
Joe. And
excellent.
If you want, you can go one more slide. I'm going to remind you that this talk today was a preparation for how to take this basic knowledge of these basic ECMO strategies and really find out and look at what is going wrong and how to change things so you can optimize your ECMO therapy. And that's going to be the talk tomorrow. So I just wanted to remind people about that.
That was really, John, that was excellent. Very, very, very good. I did notice you may want to correct, can I tell you, I think you do have to correct one of your slides. Am I allowed to say something? You saw it? Did you see the error?
A little while ago, earlier today, I found a bunch of errors. So I wouldn't be one on there.
Here, let me bring it back to you. Can I go back to the slides? Okay, I'm going to go. Oh, there you go. Oh, can you go to the last one? Hold on. They'll do it. They'll go to the last one. It'll be easier for me to go backwards. Because otherwise we'll have to click,
in my strategy of,
and we'll open the lines, the phone lines up too. There you go. Okay, is that? Yeah, there you go. There's the last. Okay, so let me go back. Okay, I think it was this one. Yes. Okay. The issue, I think what you need to change is on the second bullet point under pitfalls.
Mm-hmm.
You need to put a period after flow or after negative pressure. But because there's not going to be any recirculation if you're VA.
Oh yeah. That's what happens when you copy.
Don't copy and paste, John. Don't copy and paste. Okay.
That's what happens when you copy and paste.
He got busted on that one. All right.
I got busted. All right. Okay, there you go.
So you want to let's open the phone lines up. They are open. And can you leave that up and also put my slides at the same time? No? Oh, you can't leave the phone lines open and have my slides at the same time? Or can you? Yeah, hold on. They're going to try to do that. So I'm just going to go through a couple of slides. John, that was a really good comprehensive talk. And I'm going to sort of do have a little fun with mine in preparation for yours tomorrow. So
great.
let's see how this works out, if it works. And we're just going to press right on.
Okay.
Okay, so you can't? Oh, hold on. She's still trying. So we're going to keep the phone lines open. So while he's doing that, David will take care of that part of it. So I'm just going to go to patient 1. Okay? And so here's my question to our audience. It's a 26-year-old female. She has a gestation period of 27 weeks. She has severe preeclampsia. Her ejection fraction is 20%. Her SaO2 is 84% on maximum ventilatory support. She's in fulminating pulmonary edema. And the plan is to do an emergency C-section and immediately go on ECMO. How do you want to cannulate this patient and why? So I'm not going to answer the question. I'm not going to know answers. I'm only going to ask the question. That's all. So when we come back tomorrow, when you give your second part, you may actually be addressing this very thing. But if you don't, then we'll throw it back up there. But I'm not giving you any answers at this point in time. So then I'm going to go to another slide if I can, if y'all don't mind indulging me just a little bit. And this slide here is very important. This is an algorithm straight out of ELSO that if you have refractory hypoxemia with a Murray score of 3 to 4, or you have refractory hypercarbia up in the top bars you see here, right there, okay? You follow the various algorithms. Hypoxemia, cardiogenic shock, no cardiogenic shock. What do you do next? If it's not cardiogenic shock, you go over here. If there is cardiogenic shock, you go over here. For all other heart failures, or if the heart failure is due to hypoxemia. Now, you see where I'm going with this, right? So this should help you answer this question. So you can find this, you can download it online, very easy to find. If not, you can just freeze frame this and download it and look at it and explore it. And look at this, and look at this, and then tell me what we should do, and tell me what you think we did. Okay, so that's all I'm going to show on that. The other thing I'm going to show is some of the, let's go to, there's some of the same slides you had. I'm not going to spend any time with this. Are you going to go over this one as well, John?
I'm going to mention it, but no, why don't you go over that?
Yeah, say that. You are?
I'm going to mention it briefly, but not in detail. So
no, that's fine. Well, we can discuss that, of course. So I'm going to go to, there's some more stuff. Don't be this guy. Never use VA ECMO with peripheral cannulation, FEM for pure pulmonary failure when there is no LV dysfunction. Why? Why? I'm asking the audience. If anybody wants to call in and tell me why, do it now. If not, tomorrow, we're going to go over this as well. Is it tomorrow, John? It is tomorrow, yeah.
Yeah.
Here is a TEE of a left ventricle. You see the mitral valve, and you see tremendous displacement of the interventricular septum. That ventricle is huge. Again, there's a reason for that. This patient is on VA ECMO. John, I'm assuming you're going to go over this tomorrow as well, because I think this is another very important point. And how do we manage this? What is the best way to manage this?
LV distension and LV drainage, yep.
Yep. And then
I'm talking about that.
Yep. And then I'm going to, let's go to this slide here. Here, there's your foot.
Yep.
There's your foot. The one
Yeah,
on the
exactly.
left is before the SFA line, the peripheral cannulation, and the one on the right is after, and you can see it certainly got better, not perfect, but it's moving in the right direction. But you can definitely see an enormous difference. So I wanted to go here. You can even see an SFA line in here. Now, this is a test. I'm going to even, let me go to the slide. You could win a prize. Anyone can win a prize. All you have to do is call in tomorrow or call in today, if you know the answer, and answer the question. So, what are we looking at? And this is the reason, okay? If you look way down here, right here, you can see you've got a blue line coming into it, and you can see you have another line coming into it right here. And that line, if we follow it up, is coming from right here, right? No, is that it, John? Let me see.
I think it's the one below it, actually.
It's the one below it, right here, yes. This is the one, that's it, right there, exactly. So this line and this line are draining back to the patient. This line and this line here, this line here and this line here are pumping into the patient. So you have red blood going this way, you have red blood going this way, right here, going in right there, and you have drainage coming here, and you have drainage coming here. But what do you notice about the color of this blood right here? This is access. What do you notice about this?
It's pretty bright.
Very much brighter, but yet it's access. So access, return, return. Why is this access bright red and this access not bright red? That's going to be the question. Tomorrow we'll bring it back up again, and anyone who gets that right, including you, John, can win a prize.
Was that the preeclampsia patient?
No.
Oh, okay.
So nope, but it's very good. You can go back and look at it anytime. Here's some of our resources. I just wanted to show you that, and I wanted to show you my granddaughter's favorite character, Mr. B. So you can take our slides off, and John and I can just have a discussion.
So Joe, why don't you at least go back to that Protect Duo Canyon slide, because I felt this today, the lecture was basic ECMO to build a platform.
Yes.
Tomorrow,
do you want me to send you this slide?
Yeah, so I wanted, this is the Protect Duo cannula. And the nice thing about this, and the interesting thing about this, is that different from the two that I showed, which was the Avalon and the Crescent, they cannot make this sharp of a turn. The two that I showed cannot make this sharp of a turn and make its way from the right atrium, take a hard 180 almost up into the pulmonary artery. This cannula is capable of doing that, and it takes blood in at the right atrium unoxygenated and delivers it in this configuration to the pulmonary artery. So it is a VV ECMO with right ventricular assist support. You see, it's the same as a right ventricular assist device, because you're unloading the right atrium and you're bypassing the right ventricle, delivering blood for the right ventricle back into the pulmonary artery oxygenated. So this is the only cannula that can do this. Now, because my lecture was basic, I didn't want to get into this one, And tomorrow we'll have to see, because I got a lot of things that I'm talking about that are pretty involved also. But what were you going to point out when you had this on your lecture there, Joe? What was your point?
I was just going to point out, if in my lecture, what I was going to point out, and what I've done before, is that you notice that you have much lower flows. It's not an easy cannula to put in at all. It's not as flexible as it seems. And so it's very difficult really to get this up into the proper position. The flows are lower, but you have a lot less recirculation. You have no recirculation in essence, because of the configuration of it, draining here, returning here after 2 valves. Even though those valves are no longer competent, because of course you have this cannula stuck through it, but it does really reduce recirculation. But you improve that, but you do have some sacrifice. That the flows are 3.9 liters max, and really that's hard to achieve without very, very high RPMs. I think it's very good for some right ventricular support. I don't really think it's a good first line for VV ECMO. And besides that, it's like the Tesla ludicrous speed. Its price tag is ludicrous as well. And I think that's something that just needs to change. I think they charge for their whole kit, it's about $18,000 per kit, and just the cannula, which you cannot buy here in the United States, you can in Canada, is $11,000 just for this cannula, whereas an Avalon catheter is somewhere in the neighborhood of $2,500.
Yeah, for a while we were opening the box just for the cannula. We've since stopped doing that, and we don't really. We almost act like a university setting at our hospital. We were used just about everything for the experience of it, but I think we had to stop even with this because of what you just said.
Yeah, well, that
you know, a lot of people can get by with almost 4 liters of support, but a lot of people cannot.
Yeah, but 4 liters is 4 liters for us. I mean, the times I've had the opportunity to be someplace that was using it. So bear in mind, I have never actually just used it myself, but I've been someplace that was using it, and they were flowing about 3 liters and couldn't go any higher because of RPMs being at essentially at a max rate. So I don't know if you saw that or not. Did you see compromised flows?
In general, as I was pointing out, it's nice that you have one cannula, you stick it in, you've got total VV support with the Avalon and Crescent, and you can flow decent with those, but it's not like having 2 separate decent sized cannulas, and the flow and the pressures you're like, wow. When you see somebody who's on VV, FEM, or something like that, your pressures and flows compared to what we always see with these single cannulas are much reduced, you know, and you can flow more.
No doubt.
And, you know, tomorrow I'm going to talk about why is that important. The patient's cardiac output that is coming through the right atrium and coming around, their cardiac output, if it is very high, which it can be in sepsis and things like that, you can have cardiac outputs of 10, 15 liters a minute, and you can only flow 3 or 4 liters. That's all you're capturing. That's all you're oxygenating. Yep. This is a pitfall sometimes of VV ECMO, that you can't flow more like what you're saying here.
And that's where you get into the exotic cannulations you're going to talk about tomorrow, VV ECMO or VV VA ECMO. And I think you can also treat that hyperdynamic state and actually work towards reducing their cardiac output to try and get some some oxygenated blood to the tissue. But of course, if they have vasoplegia and all these other, in fact, Dr. Simpkins is going to be giving a talk on treating vasoplegic syndrome. And they have a very good solution to that. And because it's an overproduction of nitric oxide, and if you can reduce that, and clear it, then you're going to have, because of course we try methylene blue and we try all these fancy maneuvers, and very little works. Now, of course, there's the cytosorb if you think it's cytokine storm, but if it's vasoplegia syndrome due to overproduction of nitric oxide, you've got to clear the nitric oxide, and that's all there is to it. I also wanted to show you this other thing in my slides that I thought was very important. Are these the new ones? Because I never saw it. I didn't see the recirculation. That's not the ones I sent you, the second set. No, it's not. So I'm going to put this back up and go over this again. Is there anything we could do to get it up, or is it impossible? You could try? Okay. So I want to go over this again. So here is an access catheter going down. There it is, making that little loop, going like this, and this is going to the inlet of the centrifugal pump of the ECMO, and then to the oxygenator. And then here you have, coming from the outlet of the oxygenator, your return going to the patient, and here going to the patient. So you have access, access, return, return. This is blue or dark blood. This is bright red blood. This is bright red blood. This is bright red blood. So your two access are different color. One is dark red or blue, and the other is bright red. The question is, why and where is this cannula tip? Why is this happening? So that's my question for tomorrow. Do you want to just put up the website I want you to put up, maybe? Would that be easier? What would be easier? Huh? Okay. Hold on. He's going to throw up my other slide deck, which has what I was looking for. So just give him a second. So that's really good, John. That was a very good basic understanding of it. I'm excited about hearing about the more exotic cannulations because, I think, we have this conversation all the time. Early intervention, you always seem to have better outcomes. If you put it in when your PaFiO2 ratio is maybe down to, 250, 280, and you don't wait until it's 140 or less, your chances of having a more positive outcome seem to be so much better. And I think ELSO is now saying that if you have been on the vent with maximum ventilatory support, PEEP 15, and peak pressures at 30 and above for the past, 5 days, you are no longer a candidate for ECMO because it's an unrecoverable amount of trauma to the lung.
Yeah, on one of my slides where I said contraindications, it sort of said if you're a mechanically ventilated patient, it kind of said it in a nicer way than what you just said without putting numbers on it. But I think when you get to what is the line in the sand has become, is it 7 days? It once was 10. I think it's down to 7 days on the vent, and you should have been on ECMO. A lot of people are saying we've missed the window.
Yeah,
but
absolutely.
I've seen it, but
so is it 7 days? Because I thought it was 5.
Well, it's probably reduced. At one point, it was as high as 10, and I think it was around 7, but maybe down to 5 because even at 7, your success rate's pretty low.
Absolutely.
So now, Joe, I wanted to tell you
Mm-hmm.
that with the question that you're putting up there, I'm not going to answer it. I can take a stab at it, but maybe tomorrow. The thing that I'm going to do in my talk, which is interesting, is when people who come to a center like ours, and we have every hybrid cannulation, I think I've shown you a few where we've even had more than one ECMO machine on the same patient.
Yeah, exactly.
It finally occurred to me not too long ago as to when what I'm going to address is why and what are we accomplishing by doing such and such and such and such. The location of the cannulas are important, but they become and they're confusing, but it all becomes clear. I hope to bring it through tomorrow. It all becomes clear when you understand what we're trying to accomplish by adding a cannula somewhere.
Yes,
Or
absolutely.
returning an additional cannula.
Well, understanding anatomy and understanding flow characteristics and pressure characteristics is so important. And, I was going to give a talk on ECMO, staffing and specialist models and all this kind of stuff. And that's what I was really going to do today, and I opted not to. But, since you brought it up, I'm just going to go ahead and say it. I think that there are some incredibly talented people out there who are more than capable of being excellent ECMO specialists. But I feel like perfusionists, just by nature of what we do every single day, it becomes second nature to us to understand, I need to drain this, I need you to put that tube there. And we just know it because it's what we do, and we recognize things so quickly. I think ECMO specialist model is necessary. I think there are some incredibly talented people that can do it effectively and be very safe with great patient outcomes. But I think the best program, the best setup is a perfusion managed blended program. That's really what I believe. I know there's always turf wars, and I've seen it so many times, and it's not to anybody's advantage. John, I've seen it. I'm assuming you have too. If you haven't, if you have or haven't, you can feel free to chime in if you want to or not. But I've seen.
I had a private. I'm in a master's program, and last night the discussion was actually what you just said. The discussion was there was 30 of us that have to meet once a week, and the discussion's different every week. And last night it happened to be perfusion, ECMO specialists, and staffing models. And really, as you know, Joe, I've been doing ECMOs almost exclusively for going on almost 2 years, and I've been at least a dozen, 15 places or more with ECMO. And here, as an old-time perfusionist, I never wanted our field to let go of technologies. We let go of balloon pumps. We've been trying to give away ECMO for 30 years, and one day we're going to succeed. Mm-hmm. And I don't know if we're going to regret it or not. I think one day you just very well might.
Well, I don't think we should give it away. I don't believe we should give it away, and I disagree with that. But I don't want to blow. I just want to make sure I'm clear.
Yeah, I'm sorry. I don't like us giving away much of anything, but I realize it's a manpower thing. But here's the mistake that I think that we're making as perfusionists. If we were to, if there's going to be an evolution of ECMO specialists that come along and it's going to become its own field, they should be entirely under perfusionists.
Well, I agree with you.
Auto-transfusionists once were entirely under perfusionists. What's happening is that they're not always being under perfusionists, and the movement is for them to be sort of under administration, under nursing, on their own, and operate as perfusionists light. Now, we keep getting drug in and drug out, and when something goes wrong, I can assure you it's going to go very wrong. Maybe it will, maybe it won't. But let's say, for example, what just happened with COVID, they shut down all the routine cases. There isn't really that much ECMO, but at least there's some. What if we didn't have, we'd be doing nothing at all. We're almost doing nothing now.
Yeah, I don't think, and I appreciate that. And I recognize that's an economic issue. That isn't my reason though, and I have really worked hard to remove from my equation that aspect of it, because at the end of the day, that's not our first objective is providing great patient care. That's it. Yeah, we need work. I recognize that, and yes, that did happen with the COVID. But I don't think that not having anything to do. Look, I mean, there's heart surgeons I know. They say it, now maybe they really don't mean it, but I think that as physicians, they probably do deep in their heart believe that heart surgeons, that it'd be great if we could literally stamp out the need for coronary artery bypass grafting. But it's still one of the most prevalent operations done in our country every year. So, you know, there's a be careful what you wish for, that they come out with Drano for the coronary arteries. You know, it's likely not going to happen. Just like I think it's highly unlikely that, you know, ECMO one way or the other is going to be the savior or demise of perfusion. Perfusion is just too versatile and too many other things coming around. Yeah. I think for me, it's blended programs make the most sense. And I was going to say this earlier, that I think there are turf wars. I do think that, you know, that some departments of ECMO specialists feel like, well, we should just be on our own. We don't need the perfusionists anymore at all. And I think that's an enormous mistake. I don't think you can legislate it. We've tried that and it doesn't work because you cannot exclude people from being able to do something. But you can make people inclusive, which is what state licensure did. But in a nutshell, it didn't do anything to protect our profession in any way, shape, or form. I think we need to get involved. I think we need to be involved. And I think that the best ECMO programs will flush themselves out as time goes on with what is the best policy. Is it to have a blended program with perfusion managing it, but specialists working with them? And that doesn't mean they work necessarily under you. It means that they work with you, but there has to be somebody who is, you know, giving direction and how circuits should be set up or what systems we should use and so forth. So it should be a collaborative effort, because I think there are some super smart people out there. But when it comes to having to figure out a circuit because you're confronted with some unique problem, as in that one that I just showed you with that, where that cannula is, that requires an awful lot of experience that you cannot get from just doing ECMO. That requires the surgical understanding and knowing what's inside that chest with your own eyes and being able to basically look at the vascular anatomy in a 3D representation, looking through the patient's skin and bone and tissue and everything else, because that's what we do every day. So I think blended programs are the appropriate thing, because I think we do need increased manpower. A very straightforward, stable VV ECMO, you know, once they're on and they're stable, does not need a perfusionist at the bedside 24/7. But there should be one available for if something is going haywire, so that there's somebody there that has that innate skill, if you will, to manage those kinds of problems. That's my viewpoint. Okay, so Joe's opinion for the week.
Yeah, I mean, it's different everywhere, but is coming from home fast enough to solve a crisis that you're just describing?
Telemedicine is. You can do an awful lot with it. You can see it, and you know what to do before you even get there. You can tell them what to start getting ready. Or they can do it, you know, with your supervision or with your suggestion or whatever it may be. I think putting the patient on ECMO is the initial. Now, having one person like at a big center where you have multiple ECMOs going at the same time, I think it makes sense to have one perfusionist in-house 24/7 that's available. Yeah, that makes a lot of sense. But for the community hospitals that only have one ECMO, they can run 2 heart rooms, and they have two surgeons and only 2 perfusionists. So they can't be there 24/7, John, and you can't always find people to come in and do it. ECMO specialists are a needed asset in the ECMO world as it evolves and it becomes more and more something that we do. Something that's utilized more frequently and in places that heretofore don't necessarily have it.
Yeah, my point was not so much financial. It was more who is supervising them, and if it's not perfusionist, now it's some other department. And by the nature of human, by human nature, there's going to become a turf war.
Yeah.
Because you have a different department who is in charge of this ECMO specialist, whatever you want to call it, and they are going to want to stand largely on their own at some point, as they could or they could not. It all depends on the leadership. But my point is, you know, we've been so lucky in perfusion that new technologies that have come along have actually been added to our list of things to do rather than substituted away other ones. You know what I mean? Like, for example, the what is it? The one in the cath lab now with suctioning clots.
Oh, the angiovac.
Yeah, the angiovac, and then you have HIPEC, and these things come along that, okay, you know, the perfusionist is doing them. Rather than technologies that have substituted what we do out, we've actually been added on to a lot more than
absolutely.
And so in that way, you know, we've been lucky.
Absolutely.
And the manpower thing always rears its ugly head. You know?
Yes, absolutely. But again, I think that the most successful programs will be the ones that use the interdisciplinary blended approach towards the program, and I think the ones that people who, you know, who may be very smart but believe I don't need you, given and not respecting, you know, we want to respect them and their knowledge base and their experiences, but it has to be a two-way street, and when one of those directions doesn't work for some reason, then what happens is their program doesn't do well because their outcomes are not very good, and then they make change. So that's kind of, I think, how it all ends up evolving. But anyway, with that said, let me go to my slide. I wanted to point this one last thing out. On recirculation, there is a Transonic company up in New York, Ithaca, New York, makes the ELSA-meter. And this is a fascinating device that I've had an opportunity to use, and it is incredible. So regardless of whether you're doing dual cannulation or single cannulation technique, you give a single injection here of 20 cc's, and it measures the recirculation as you're pumping the blood back in and accessing it back down with sensors that are placed on the venous and the arterial systems. And what you get is a readout that looks like this. So it does two things simultaneously. This is just set at recirc, but it actually measures intra-oxygenator blood volume. So you know if your oxygenator volume is going down, the only thing it would be is clot. So you know that you're losing surface area in your oxygenator. But in this particular case, you see that the recirculation is 50%, meaning that your effective flow, now this is on a child, obviously very small flow. You have flow of 640 milliliters a minute, but you can see your effective flow is only 320 milliliters a minute. And that would be the same if this was, 5 liters and it was 50%, then this would be 2,500. So you can see what your effective flow actually is and what percentage your recirculation is. So you can adjust your cannulas to get your recirculation down below 20% or below. I've seen it as high as 38%, and I've also seen it as low as 15%. And let me tell you what, there is an enormous difference in your arterial saturations when you have this number as low as you can possibly get it. I've never seen it below 15%, but I have seen 15%, but I've also seen as high as 38. This was just an image that I got off of the internet, and it's pediatric. But it's very simple to use. I'll go back and show you again. The meter sits on a table. You throw your arterial sensor on, your venous sensor, it's all external. You give your 20 cc bolus of well, not necessarily 20 cc's. It's a set amount. So in a baby, it would be a lot less. In an adult, it would be 20 cc's. So keep that in mind. But basically, it takes into consideration how much volume is in this line right here. The saline goes up, and whatever part of that saline immediately comes back gets picked up right here, and then gives you the calculations. Really interesting technology, and I highly recommend anybody watching this program go to transonic.org, or transonic.com, transonic.com, and take a look at the ELSA-meter. I think it's a very, very powerful tool that should be used. I'm done with my slides, David. Thanks. Okay, perfect. John, any final thoughts?
Well, what you just brought up there on the ELSA-meter, I am going to touch lightly on that because I agree with you that it should be used pretty much. It should be in every ECMO center.
Yeah, I think it should be a standard of care. I don't think you should do ECMO without it.
Yeah, and I know more and more are acquiring that, but tomorrow maybe you can have that slide and some other similar slides, and we can interplay back and forth. I don't have a slide quite as good as the one you just put up there. I'm still polishing up part of that lecture, but that is something I wanted to touch on. Recirculation is what I wanted to touch on. The pitfalls and how to cure some of these things that we talk about, like north-south syndrome. You know, what is the cure for that? What can we do to fix it?
Oh,
we
it's a nightmare. It's one of the most insidious problems that you can have, and there's not a lot of ways to fix it. I know there's ways, but there's not a lot of ways to fix it.
And we're going to go over a few. Yeah, right. Some of them are nice thoughts, but they don't work.
Mm-hmm.
But there are ways to fix it. And I like I said, I want to try to point out to people, you know, step back and look at all these different hybrid cannulations. Rather than sit and memorize what each one is doing and why, you can actually digest. If you know what the person, the surgeon or whoever did this type of cannulation was trying to accomplish and what problems they had, you'll see that what they did resolved and fixed the problems, and that's why you're doing certain things. And
Absolutely.
I think that'll make things a little simpler.
Well, I want to add something to what you just said, if I can, please, and that is not only is it something, you know, the Harlequin syndrome or north-south syndrome or differential hypoxemia syndrome, whatever you want to call it. I mean, I know there's all kinds of different names, but it's not just how do you fix it. It's so important to know how to recognize it. Mm-hmm. That's really important because I've seen it go unrecognized by a lot of really smart people.
One of the sections that I'm going to talk about is ECMO monitoring. How can you up your game? That's actually the little section that I called it, because I think there's some simple things we can do with some simple machines that most of us have out there in our hospitals that make a whole lot of sense, and a lot of times they're not used very much.
Yes, agreed.
And I'm going to talk about a couple things like that.
Agreed. Perfect. Very good. Okay, well, with that said, I think we'll go ahead and end for the day. Looking forward to seeing you tomorrow again at 5 o'clock Central Time. Please, if you haven't already, go to slido.com and make sure that you do the survey. John, if you could do that too, I'd appreciate it. You can go back and watch the video and just put your phone QR reader up to it. It'll take you right to it. Or just go to slido.com and put in what is it? It's Perfweb C30-8, right? But it's in the video. You can go back to the very beginning and see it because this video will stay up, obviously. That's it. You know, we're just looking forward to seeing you tomorrow. And thank you again so much for taking the time out of your busy schedule, your day off, trying to, you know, probably take a break and relax. I know you work all week, but we appreciate you, and all of the staff, all of the audience out in web world appreciate you too, John. Thank you.
All right, Joe. Thank you so much.
And we'll see you tomorrow.
Thank you.
Bye-bye.
Mix Cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mix dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.